going to have 3 cases regarding the topic of neoplasia. We'll start with case number 1. We have a 20-year-old female patient presenting with a round mobile breast lump, a round mobile breast mass. She has no family history of breast cancer. So from this history, you can notice that we have a female patient. She's young, she's 20 years old, and she has a mobile breast lump, breast mass. Okay, mobile breast mass with no family history of breast cancer. So what the doctors did was a test called FNA, fine needle aspiration. So in fine needle aspiration, this was what the doctor does. You will locate the mass and insert this needle into the mass. Aspirate and take whatever cells you get inside the needle and place them on a slide. You view them under the microscope, and this is what it showed. Well, it showed this cohesive cluster of cells, uniform cells. The image is not that clear, I know, but the findings were benign smear of cohesive uniform cells of 2 types. So we had a benign smear, no signs of malignancy in those cells. They were cohesive, attached to each other, uniform, same size, same shapes, and 2 cell types. So the most likely diagnosis is going to be fibroadenoma, which is a benign condition composed of 2 types of cells. So fibroadenoma is a benign breast lesion, encapsulated tumor of the breast composed of 2 cell types. We have ductal cells or epithelial lining cells and stromal cells, fibrous tissue. So we have 2 types, ductal and stromal cells. So it is considered an example of mixed tumors of the breast. And you have points to take about fibroadenoma. First, it occurs mostly in young patients. It's a benign lesion, encapsulated, composed of 2 cell types. And clinically, you will feel it as a mobile breast mass. Okay, this is a fibroadenoma grossly. Here we have this lobulated texture. We have lobules. And under the microscope, this is how it shows. You have those this proliferation of stromal cells. Here we have the stromal component, the stromal cells, and in between you can see those slit-like spaces or compressed ducts, epithelial cells. Those darker cells are epithelial lining cells of the ducts, compressed by proliferation of stromal cells. So the behavior of this tumor, we said that this tumor is a benign tumor. It is a benign lesion. And malignant change could happen, but it is extremely rare. So we have features differentiating or distinguishing between a benign and a malignant lesion. We have 4 points. First of all, circumscribed growth goes with a benign lesion. So if we have a benign lesion, it usually has a circumscribed growth. If it's malignant, it usually has what we call infiltrative growth. It infiltrates into the surrounding tissue. The rate of growth, it's usually low in benign lesions while it's higher in malignant lesions. Differentiation, the rate of differentiation. Whenever you have a well-differentiated tumor, you should first think about a benign lesion. It might be malignant, but it's usually benign. Poorly differentiated lesions are usually malignant. Metastasis occurs mostly with malignancy, not with benign lesions. Now we have the second case. She's a 30-year-old female patient with a hard mass in the breast of several months duration. She has a strong family history of breast cancer. So she's slightly older. She has strong family history of breast cancer, and she has this hard mass in the breast of several months. So we have some genetic abnormalities associated with breast cancer, which are the genes BRCA1 and BRCA2. Either of those might be involved. Investigations done. This patient underwent mammography, FNA, fine needle aspiration, chest X-ray, ultrasound, CT, and MRI. Chest X-ray, ultrasound, CT, and MRI were done to assess if there is any metastatic lesions in other sites of the body. So a mammography, this is a mammography device or mammography machine. It generates an image using X-rays. So this is the image we get using a mammography. This is the normal breast tissue, this hazy material here, and in the center you can see this dense area. This dense area with stellate appearance, this is probably a malignancy or cancer. And this image shows a breast, and in the center you can see this wide dense area, small, which is a microcalcification, usually associated with either DCIS, ductal carcinoma in situ, or malignancy. Now, an FNA was done for the patient and showed this image. You can see those clusters of cells, and they are hyperpigmented, or we call them hyperchromatic. The chromatin is darker than normal, and they are clumped, forming those clumps or clusters of cells. They are pleomorphic. They have no uniform shape or size. They are different in shape and size, and they have this distinct chromatin pattern, which is not fine chromatin, but otherwise we call it a vesicular or open chromatin. So, never mind. You have to focus on that pleomorphism, or different shapes and sizes of cells, goes with malignancy. And prominent nucleoli, those are the nucleoli. They are, just a minute. Okay, so the Pap staining of the same cells will show nuclear features more prominently. And here you can see those dark orange dots or spots, which are the nucleoli, which are become more prominent when there's a malignant tumor. So the diagnosis was a cellular smear with pleomorphic cells, mostly malignant. If you notice, it's not a definite diagnosis, not a definitive diagnosis, because it was done on an FNA, fine needle aspiration. We just take some or few cells from the mass, and thus we cannot make a final diagnosis. So this FNA testing just guides us what to do next for the patient. And this patient, the surgeon took back this diagnosis. It's mostly malignant, so he decided to put the patient for operation. And when inside the operation, he did what we call a frozen section. So what's a frozen section? A frozen section is a test done by the surgeon while the patient is in the operation room. He takes part or a piece of the tumor and sends it to the pathology lab. And in the pathology department, they freeze the tissue. Okay, so they process the tissue by freezing rather than putting them in paraffin sections, because it takes longer time. So they freeze the tissue. We cut a small slice, put it on a slide, and examine it under the microscope. So now we have not only just cells, but part of the tissue. So we can make a diagnosis. And we give them a diagnosis within just 10 to 15 minutes. So the doctor took back the diagnosis, and he wants to decide whether just to do a wide excision or to do a mastectomy, depending on the diagnosis of the tumor. This is the tissue sent after the operation. And here you can notice the yellowish area, which is normal fatty tissue found in the breast, and in between you might see those ductal elements, or might be fibrosis. Never mind. In the center here we have this dense area, irregular in shape, and infiltrating into the fat. So this is breast cancer. It's not a benign lesion. It is not encapsulated, not well defined. It is infiltrating into the surrounding tissue. So this is a malignant lesion. The tumor was hard as well. When cutting it, it was hard and gritty. Why is that? Any tumor, or usually tumors, develop what we call desmoplasia or desmoplastic reaction. This desmoplastic reaction causes, which is a dense fibrous stromal reaction surrounding malignancy, causes the tumor to be hard. And under the microscope, this is how it shows. We have those malignant ducts or malignant glands, malignant cells forming glands, and in between you could see these pinkish material, which is fibrous material, in between the malignant cells. This is what we call desmoplasia. So this patient had a breast mass, and she had enlarged axillary lymph nodes as well, and a mass in the lung. So those will probably show metastatic ductal carcinoma inside the lymph nodes and inside this lung nodule. And this section was taken from the breast. And if you can see, here we have a lymphatic channel, and down there we have another lymphatic channel. But within the lymphatic channel, you can see those ugly-looking cells, which are malignant cells. So these are tumor cells inside lymphatic channels, causing then spread to lymph nodes. And this is a lymph node cut in half, and it shows this different-looking area, which is most probably malignancy or metastatic tumor. And this is how it shows under the microscope. So under the microscope we have this lymph node. This is the capsule of the lymph node. Underneath you could see the normal lymphoid tissue. And in between we have those malignant looking glands or malignant cells forming glands, a metastatic cancer into a lymph node and forming this desmoplastic reaction surrounding them. This section is from the lung of a patient. The next section, yes, it's from the lung of the patient, and here we have the normal lung tissue, and here we have this nodule of metastatic tumor, also forming glands. So it's the same tumor. Now, this image shows what we call angiogenesis in tumor metastasis. So even tumor metastasis, not only the primary tumor, even if the tumor metastasizes, it will form new blood vessels surrounding the malignant cells in order to nourish and complete its growth. So in order to grow, it needs blood supply, and this blood supply will develop surrounding the even the metastatic nodules. This section is from the pleura, and here we have the underlying lung tissue, alveolar spaces, alveolar walls, and overlying it we have this stroma, which is the pleura, the pleural lining, and within the pleura, the normal pleural tissue, we have those darker looking cells, irregular in shape. Those are the metastatic cells into the pleura. So the surgeon had defined a diagnosis, invasive ductal carcinoma of the breast, and he asks for more tests, for other tests from the pathology department, which are immunostains, immunohistochemical stains for estrogen receptors, progesterone receptors, and HER2 receptors. Okay, so any patient with breast cancer, the surgeon will need those studies, further studies on the tissue, in order to determine whether the tumor is estrogen receptor positive, progesterone receptor positive or negative, and HER2 status. Why is that? In order to know how to continue the treatment, to guide him for further therapy and to assess the prognosis. So this is an image from the ER immunostain, and it shows nuclear staining, prominent nuclear staining in tumor cells. Those are the nuclei of tumor cells, which are dark brown, positive for ER, estrogen receptor. While in this image, we have the HER2 positivity. The HER2 positivity is not nuclear. Here we have the nuclei, they are not positive. The positive or the darker thing is the membrane, the cell membrane. So it has membranous positivity because it is a receptor on the membrane. So HER2 is an epidermal growth factor. It's an epidermal growth factor of oncogenes. So it is an oncogen, and it's found on the cell membrane of cells. It's overexpressed in high-grade. When a patient has a tumor which is HER2 positive, has HER2 overexpression, then it is effective to use anti-HER2 therapy. Some of those drugs, like Herceptin, are called anti-HER2 drugs used in such patients if the HER2 is positive. So the patient took chemotherapy, hormonal therapy, but unfortunately died within 1 year after the tumor metastasized. So those two cases were about breast cancer. Now we have a third case in a 28-year-old male patient complaining of nausea, vomiting, abdominal pain, and bloody stool. So all of those symptoms are derived from the GI tract. So he has a family history of uncle and a grandfather dying of colon cancer, and his liver is enlarged, and certain investigations were done, including chest X-ray, abdominal ultrasound, and a colonoscopy. So what did those tests reveal? First, let's start with the colonoscopy. It showed hundreds of polyps throughout the colon and an ulcerating mass in the sigmoid. So this patient had hundreds of polyps and an ulcerating mass in the sigmoid. The ultrasound showed that the liver was enlarged by multiple nodules. It has multiple nodules within, and the chest X-ray showed multiple bilateral opacities in the lung fields. So what does this all suggest? This patient has a malignant tumor arising from one of those polyps he has, and it metastasized to the liver and the lungs. So the most probable diagnosis is what we call FAP, or familial adenomatosis polyposis. It might lead to malignant transformation of one of those polyps into adenocarcinoma. So we have high grade of malignancy in this inherited form. The genetic alteration found in such patients is germline mutation in one copy of APC gene, and followed by other mutations which will cause further steps in the carcinogenesis. So the cancer will develop after having other mutations in other genes, or in the other copy of the APC gene. So this patient will have an APC gene mutation when he has a normal colon mucosa. Afterward, which we call the first hit, so he is predisposed to have malignancy. And at the end or at the final steps, he will have what we call P53 mutation. So this is what you should concentrate on, that APC occurs early in the course of disease, and P53 occurs late in the course of disease. In between, there are multiple genes to be mutated or might be mutated, such as the other hit of APC, or beta-catenin, even KRAS, and those will lead eventually to cancer formation, or adenocarcinoma of the colon. Now we have an image of a colon stuffed with polyps. Those are hundreds of polyps inside a colon segment. And this is one of those polyps sectioned and put under the microscope. Here we have the normal colonic mucosa. At the lower part we have the normal colonic mucosa, and here at the surface of the polyp we have those darker looking glands. Those glands have darker nuclei. The cells are what we call dysplastic. So dysplasia has occurred. This is the process of dysplasia. Here we start with the normal looking mucosa. You can see those clear areas which are the mucin deposits inside the cytoplasm, and here we have those dysplastic cells. So this is dysplasia, darker looking nuclei, stratification. Those cells have their nuclei at the center, at the base, while here we have irregularity of distribution of nuclei. So they are darker, they have loss of differentiating factors. Now we are going to list all those features of dysplasia. Okay, this is a very expected question on the exam. So features of dysplasia, we have high NC ratio, high nuclear to cytoplasmic ratio. When the nucleus gets larger, then the ratio between the nucleus and the cytoplasm gets higher. So the nucleus to cytoplasmic ratio is higher. We have pleomorphism, different shapes and sizes of those cells. Loss of differentiating features, such as the apical mucin usually seen in the colon mucosa, it will be lost. So loss of differentiating features. Hyperchromatism or hyperchromasia, which is darker color of the chromatin or the nuclei. Prominent and sometimes multiple nucleoli. Increased mitotic figures. The tumor has a high turnover rate and high growth rate, so we will find higher or increased mitotic figures. And some of those might be abnormal, so presence of abnormal mitoses. And loss of polarity in an epithelial surface, as I said before. So the nuclei will not be all located at the same level. Some of those will be at the base, some of those will be at the superficial area. So loss of polarity in epithelial surface. Now we have an image of a polyp. This is a big polyp, and here we have an invasive adenocarcinoma. So adenocarcinoma will show as malignant looking glands, and in between you can see what we said before, a desmoplastic reaction. So we have those malignant glands and a desmoplastic reaction in between. This is an adenocarcinoma. This is an image of wall invasion. It's not that clear. Now we have it at larger magnification. You could see more clearly that we have this. This is the mucosal surface. Here we have adenocarcinoma of the colon, and those malignant glands have spread and dissected between the muscle wall into the muscle wall of the colon. Here we have the normal musculature, normal muscularis, and those glands dissected in between the muscle fibers into the wall of the colon. So this is wall invasion by adenocarcinoma. Now this image shows a liver with multiple white nodules, which are metastatic nodules from a colon, probably, most probably. Now we have another liver with metastatic nodules as well. This is how they show on HD staining. Here we have this nodule formed by malignant-looking glands, and surrounding it we have the normal liver tissue. So we have normal liver tissue, and in the center we have this malignant nodule of metastatic tumor. Now we have this lymph node. We saw it earlier in the case of breast cancer. It's the same lymph node. So normal lymphoid tissue, a capsule, and those malignant-looking glands. So metastasis into a lymph node from a breast cancer might look the same as that from colon cancer, because they both form glands or glandular structures. So we call it a metastatic adenocarcinoma, and the surgeon is going to go back and look for the primary site of the tumor. Okay, so this is metastatic adenocarcinoma into a lymph node. This is what we call transcolomic spread of tumor. So the tumor has many types of spread, many roads to spread through, and one of those is called transcolomic spread, spreading along the peritoneal surface or the pleural surface and forming deposits on other organs, such as those white deposits, which are metastatic deposits on abdominal organs. So the first patient we talked about had what we called FAP, or familial adenomatosis polyposis. Now we have another type of inherited colon carcinoma, which we call HNPCC, or hereditary non-polyposis colon carcinoma. And as the name indicates, the patient will have no polyps, just colonic carcinoma. So non-polyposis, hereditary non-polyposis colonic carcinoma. This is another form of inherited colon cancer in which patients will have defect in mismatch repair genes. So you should be able to differentiate between HNPCC and FAP and the genes associated in both. And remember, no polyps in HNPCC, while we have multiple or hundreds of polyps in FAP. Now this is an image of a colon with cancer without a polyp. Okay, so back to the roads of spread. We said we have transcolomic spread, in which the tumor will spread through those surfaces and reach other organs, such as the ovaries or the intestines, which are covered by the peritoneum. The tumor might invade directly into next tissues or tissues adherent to the tumor. Let's say we have a patient with breast cancer. The tumor might invade directly to the skin or to the underlying muscles. Lymphatic spread, which will eventually lead to lymph node metastasis. We saw lymphatic spread in the case of breast cancer. And we have hematogenous spread, spreading through blood vessels, not lymphatic channels, but otherwise blood vessels, which might lead to lung metastasis, brain or bone metastasis, or any other, such as the liver metastasis we saw earlier. So a colon will drain into the liver through the portal vein and might lead to hematogenous spread into the liver. Now we have something else we're going to talk about, which is staging of a tumor. Any tumor in the body has to be staged, and staging means we are going to determine the extent of spread of the tumor to see what we should do next, and to know the prognosis of the tumor. So to see if a patient has a tumor with extensive metastasis, you're going to think that yes, he's probably having a poor prognosis. He's not going to live that long. If he has just few metastatic lesions, then his state will be better, his prognosis will be better. Now, we use something called the TNM staging system. TNM staging system, this is an example of TNM staging on lung cancers. T stands for tumor, N for nodes, lymph nodes, M for metastasis. So any tumor in the body will be staged, could be staged by the TNM staging system. And it depends on many factors. You're not going to memorize the staging system for each, but just to have an idea, TIS in lung cancer is in situ carcinoma, in situ, which means that the tumor has not spread into the lung, but yet it's just confined to the mucosa. Now T1, we will have a small mass surrounded by normal lung tissue and away from the central area, more towards the periphery. And whenever you go from T1, T2, T3 to T4, the size of the tumor will enlarge, and the site of the tumor will get closer to the carina, or to the center, to the bifurcation of the trachea. The nodal status as well depends on the number of lymph nodes involved and the site of lymph nodes involved. So if we have those lymph nodes, just the hilar lymph nodes at one side, then we call N1. If we have lymph nodes reaching to the carina or paratracheal lymph nodes, then it's N2. M stands for metastasis, which is determined clinically by the surgeon. So why is it important? We said we have to assess the prognosis of the tumor, to know how it's going to behave next, and to know what we should do next, what treatment we are going to do. Now we have some examples of tumors that may show widespread. Small cell carcinoma of the lung, melanoma, osteosarcoma, and any high-grade phenotypic tumor. So any tumor with high grade might show widespread metastasis. Small cell carcinoma of the lung, melanoma, osteosarcoma, all might show high grade or widespread metastasis. Now we have this image. This chest image of the patient shows multiple black spots, which are multiple nevi, and one of those showed irregular surfaces, irregular boundaries, and irregular discoloration. And the center is very dark, it's black in color. And we have those other lesions budding out from it, this is a melanoma. This is an example of a melanoma. And this is a section from a brain involved by melanoma, metastatic melanoma. You could notice that the lesions are very dark in color, containing melanin pigment. So this is metastatic melanoma into the brain. And here we have a long bone with this tumor arising from it. This is an osteosarcoma. Now we have finally this image, chest X-ray of a patient showing diffuse multiple nodules or haziness. Those nodules are metastatic tumor into the lung fields. Here we have multiple nodules, and on the other side we have other nodules. So this is lung metastasis from a malignant tumor. Thank you all.